And this moment is a special moment, because at this moment there is the potential that exists within our students to spread this change and to bring about a happiness revolution. A peaceful revolution that will increase levels of well-being around the world. A revolution that will generate not just more well-being, not just more happiness, but also more health and more goodness, more generosity, more kindness. This is about making the world a better place. This is about making a meaningful difference. And when I think about it, I know that this is the moment. Right now, right here, together. Hello and welcome from wherever you are and whenever you are. I see we have people here from Peru and Brazil and the UK. Wow, you're still up at this hour, and China and the United States. Wow, really all over the world. Welcome. We have with us today a very special guest, world-leading expert on addiction and substance abuse, Dr. Keith Morgen. He's a professor of counseling and director of the graduate counseling program at Centenary University, where he's also a recipient of the Distinguished Teaching Award. Keith has written over 40 scholarly articles and book chapters in the areas of trauma, addiction, and other psychiatric disorders. He's the author of the book Substance Use Disorders and Addictions, and he's the co-author of Aging Behind Prison Walls. This book was the 2022 recipient of the Society for Social Work and Research National Book Award. Dr. Keith Morgen is a former president of the International Association of Addiction and Offender Counselors, and he currently serves as the North New Jersey Regional Director for the New Jersey Addiction Professionals Association. He operates a part-time counseling private practice, working with clients diagnosed with co-occurring mental health and substance use and addictive disorders. So we have an expert with us today, world-leading expert, but I want to say a few words on just on a personal level. So as many of you know, as part of my work and mission within the Happiness Studies Academy, for a long time, for years, I've looked for a home for the field of happiness studies, to establish happiness studies as an academic field, to create an academic degree that is in happiness studies. And I found a home, an academic home at Centenary University. Dr. Morgen made this master's degree happen. And he's been supporting the creation of it from the outset, whether it's coming up with standards for the new emerging field of happiness studies, or whether it's to elevate scholarship and teaching in the study of happiness. Just recently, a few weeks ago, I visited his class, and I was so moved by the connection that Keith had with his students and by what they were learning. And I must say, I left that class. It was a 2-hour class that passed by like 5 minutes, it seemed. And I left optimistic, knowing that these students who are future counselors, their clients are in good hands, in compassionate and professional hands. So Keith, welcome. It's a real honor and privilege to be your colleague, friend, and to have you here tonight with us.
Oh, thank you first off for the very, very kind words. It's also been an honor, a pleasure, and just a lot of fun getting to know you and working with you over these past few years.
Thank you very much. I look forward to many more.
Many more, absolutely.
Yeah, and we have an hour ahead of us. Here's what we're going to do. Keith and I are going to chat for 30 minutes or 30 hours, depends on how long we have. I have plenty of questions. And then we're going to open it up for you. Any questions that you have, just please, if you do have questions, make them brief, because we want to get through as much material, and we want to respond to whatever it is that you're interested in. Okay, so Keith, my first question is a very basic one. And it's in basic terms, how is addiction diagnosed? We all have our notions, our ideas of what addiction is. So what are the criteria that would constitute addiction?
Okay, I think that's a great first question, because addiction, though it is, widely known about and, unfortunately widely experienced by a lot of people, the actual diagnostics of it are sometimes not that well understood. So I am a professor by trade, so I got a book next to me. So give me like 5 seconds. I'm just going to sort of give you the breakdown of it, and then we'll talk about it. So the primary tool for diagnosis in the US working in mental health is the Diagnostic and Statistical Manual of Mental Health Disorders, DSM. We're currently on DSM-5. And it's going to run down really quick, and then we'll talk about it in non-diagnostic DSM terms, what all this stuff means. So some of the components that go into the diagnosis of addiction are the following criteria. Do you take it in larger amounts for longer periods of time than you intended? Have you unsuccessfully ceased or cut down on it over and over again? Like, you try to stop, you try to cut down, it just doesn't work. Spend a lot of time focused on acquiring it and then using it, and that time eats into the other parts of your life, whether it be family, friends, school, work, etc. There's a concept many people know called craving, and craving is this intensive desire and need and want for the addictive substance very frequently and pervasively across one's day. Recurrent sustained failures to maintain responsibilities, work, family, school, whatever it may be. You keep on using despite the fact that you recognize this use is causing me distress. This use is causing me dysfunction. It's hurting my family life, my marriage, my friendships, my work, my school, etc. And a couple of ones that are sort of most important is this concept of tolerance and this concept of withdrawal. Now, the concept of tolerance is basically any substance, and in reality, any addictive act. The more you do it, it takes more and more of it over time to sort of get you the same effect from it. So, for example, someone who's a hardcore long-term drinker needs much more alcohol to begin to feel the effects of it as someone who's not. The effects of tolerance. The body gets used to the ingestion of this foreign substance into the system. But tolerance is also an interesting thing, because tolerance also speaks to the biochemical, psychopharmacological component behind addiction. Because addiction is not about the cocaine or the alcohol or the sex or the gambling or the opiate. It's about the massive restructuring of the release of neurotransmitters and how they're processed at the brain and the synapse level. That's what a lot of addiction is. A lot of addiction, first of all, the primary neurotransmitter that's impacted by most substances, as well as such things as sex and gambling, is the neurotransmitter called dopamine. And dopamine is primarily the neurotransmitter, which is a chemical. It's primarily the neurotransmitter in your brain that when you feel good, that's the dopamine. When when you enjoy something, there's dopamine. When you go to your favorite restaurant, there's dopamine. Sex, there's dopamine. Dopamine is there. But what happens with a lot of these substances, to really make it overly simplified, is that, well, you just get a mega release of dopamine. And in addition to that, the dopamine hangs out in the synapse longer than it normally would. So you have more of it there, and it hangs out there longer. So you get a massive effect of the dopamine. So when you're talking, about tolerance, which is what you're talking about in some ways, is I need more and more and more of this substance, because I'm sort of my body's getting used to processing the substance, and my brain is, getting used to all this dopamine. It just takes more and more and more of it. So one concept is tolerance. Another concept is withdrawal, that the body gets used to, whether it's the substance in the system, or the body gets used to other things like the rush from gambling, the rush from sex and sex addiction, for example. And when that is taken away, then the body has an adverse reaction to that. So those are the criteria any clinician is going to run through. And if they have at least two of those criteria per the diagnostic manual, it qualifies as, a mild use disorder. Then if you have like 4 or 5, it's moderate. 6 or more severe. But you have to have those criteria. In addition, it has to last for a while. This just can't be a one-off thing, a week here, a month there. This is sustained 12 months or more. I mean, it doesn't have to be every day, but very, very often over these 12 months, this is your life. The use, the tolerance, the withdrawal symptoms, the trying to stop and not being able to, using more than you want to. So that's the general definition of addiction. And there can be 2 types of addiction. One is the substance-based one, alcohol, heroin, cocaine, those type of things. Another type of addiction is, they call it a process addiction. They also call it a behavioral addiction. Those are things such as gambling, such as sex. If you think about gambling and sex, they also target the neurotransmitter of dopamine. So, Tal, that sort of it's a very good, very large question I tried to answer in a very short amount of time.
Yeah. Thank you for that. So, the 2 words that that emerge for me as critical here are, it causes distress and dysfunction.
Yeah.
And you said, it could affect your relationships, your work, how you're doing at school, your health.
Yeah.
So distress and dysfunction. And, since COVID, I think attention to this distress and dysfunction has been at an all-time high.
Yes.
So we're not doing well as a society, and we know it. So the question is, what are some of the critical elements for sustained addiction recovery? And again, whether it's gambling or drugs, alcohol, or whatever.
Yeah, I think the main one is hope.
Hope.
I think the main one is hope. I think the main one is that there is this notion that from the client perspective, if I do this, if I engage in this, if I try to do all these things in a healthy way, that there's something better ahead. And that's the hard part about counseling. The hard part about counseling is you ask someone, in essence, to take a leap of faith. Because if you think about addiction, there's like 8 zillion different theories of counseling. But in one of these 8 zillion theories of counseling, there is this concept called discomfort anxiety. And discomfort anxiety is basically saying that the individual, for various reasons, cannot sit with negative. It's just aversive. They can't. It's uncomfortable. It's intolerable. They cannot sit with negative. And they go to great lengths to avoid negative. And in the framework of addiction, those great lengths typically are use, because discomfort, anxiety is basically, I don't like feeling negative. Well, nobody likes feeling negative. Nobody likes feeling negative. But the strategy they use to deal with that negativity is, I just want to zap it away. I want to just get rid of it. It's gone forever.
And I'm looking for a quick fix.
Looking for a quick fix. And honestly, it's unhealthy, but that is what it does, because depending upon the substance that you take and how you ingest it, you can be high in about 10 or 15 seconds. 30 seconds, a minute. So if you want something quick and you want to zap away the negativity, that is there. And think about what we ask of somebody when they go into recovery. Take a leap of faith. Now it goes from getting rid of negative to having to coexist with negative. Now it's not a matter of, once the substances are gone, the whole zapping away, turn the volume down to zero on the negativity, that's not available anymore. And then on top of that, really quick on this point too, whatever they had as a coping mechanism to sit with negative has since completely atrophied, because they've been doing the substance use strategy for so long. That's the only strategy that they've used for years and years and years. Now here they are with basically no non-substance coping strategy, sitting with negative. And that's why this sense of hope is so important.
Wow.
Because at first it's difficult and it's hard and it's challenging. And they know enough to know this feels lousy, and I know how to make it feel unlousy really quick.
So they're basically asking, what's your alternative, or do you have a better alternative? So I must say, Keith, I did not expect that answer. I did not expect you to say hope, but I find it fascinating because, we talk a lot about hope in the Happiness Studies Academy. In fact, one of the definitions that I use for depression, in fact, the way I distinguish depression from sadness is, to me, depression is sadness without hope. So, sadness is something we experience 10 times a day. But when you take away the hope component, that's when it potentially becomes depression. I think about the work of Rick Snyder, who's one of the fathers of the field of positive psychology. And he talks about hope as combining willpower, yes, I can, and way power. This is how I'm going to do it. Willpower and way power. So hope, is pervasive in the literature of positive psychology, in the happiness studies field, in interventions. And I'm very curious, how do you, as a therapist, what do you tell your students? How do you instill hope in your clients?
I think, hope has to come from within. And that's the primary challenge when you teach counseling, is that you can't make anyone say anything, think anything, do anything, feel anything. What you can do is set up a context so that over a sustained period of time, this newfound perspective can take hold. For example, hope is critical, but hope also comes along with a couple of very intrinsic things. I've been doing this for a long, long time. And, one of the things I found is, people are ready to engage in counseling and to embrace that sense of hope, it takes a combination sometimes of courage and also sometimes desperation. And those two things in some part or the other together create a moment where, I have to, the client think that there has to be something else here, but they're scared out of their wits about it because it involves feeling and thinking that they haven't done before. And if we go to the 12 steps for AA, NA, etc. Step number 4, I always talk about that step in some of my classes. Step number 4 is the individual makes a fearless moral inventory. They put the word fearless in there for a reason. They could just say, take a moral inventory of, who you are and your faults and your deficits. And no, they said the word fearless because a long time ago, they figured out you're going to hit a point where now, without the substance, without the ability to self-medicate, you're going to hit a point of fear, of desperation, of perhaps a moment where, it's overwhelming and everything about you is driving you to run the other way. And the word fearless is there to move forward.
To stay
To answer your question, how some of the ways that you do it, it may sound almost silly to say at the start. It's this concept early on. The person is lost, they're fearful, they're hurting, they're confused, they're not seeing any moment to moment dividends from what they're doing. And part of the therapist's job early on is to bear witness to that. Because there's that has to be there. Because when you bear witness to it, you respect it. When you bear witness to it, you emphasize it. And when you bear witness to it, you empower the person because they're saying, I'm afraid right now. I'm hurting right now. I'm scared right now. I'm wounded right now. And allowing the person to embrace that. And that's how it starts. And the person then begin to slowly discuss and slowly build up, the notion of, I can coexist with this. Because the overarching principle of counseling, as far as I'm concerned, is, summed up in the following statement. Stability is never the absence of negative. Stability is how you manage negative. There's a healthy way to manage it and an unhealthy way to manage it. Not the thought, not the emotion, to what you do with it. But to have that, they have to first have the comfort to express those thoughts, express those emotions.
And you as the counselor, as the therapist, or by the way, I think also as a parent, you bear witness and you create that safe environment where you're allowed to manage the negative. You don't need to run away from it.
I saw something that popped up in the chat a while ago, and I think it's important just to talk about. I saw the word awareness pop up in the chat. And I think awareness is a misunderstood concept. I want to learn a little bit about that. The concept of awareness, basically, you think about awareness. When I describe awareness, I sort of talk about awareness versus insight. And the best way how I teach it is to put it in the context of a GPS. If you're going to go from point A to point B, and awareness is, okay, let's say we're going to drive from here in New Jersey over to Pittsburgh, about a 6-hour drive away. Okay. We get in the car Tal, you're driving. I'm tired. I fall asleep. It's been a long semester. I fall asleep. Okay. I wake up just as we're driving into the city limits and I see a big sign saying, welcome to Pittsburgh. That's awareness. Oh, we're in Pittsburgh. Insight are the turn-by-turn GPS directions that got me to Pittsburgh. And that is something I think is critical. Awareness, sometimes in my experience, it's not the absence of awareness, it's the opposite. The individual is excruciatingly aware. It's the insight. And the individual does a lot of things with that awareness that they're uncomfortable with. There's something in the existential counseling literature. It's been termed neurotic anxiety. And basically, neurotic anxiety is basically you're putting on a charade. It's a facade. Because as difficult as that might be, the person does the math and figures it's easier to act as if than to embrace the awareness and start looking at the insight details that got me here. And and that's a big part of what counseling is also early on, is that, if you're going to move toward health, you first have to embrace where it's not healthy. And to act as if and pretend that's not there, that's not that bad, that's not that. That has to be addressed. I've had patients who had remarkably dangerous things happen where they tried to take their own life. And then they minimized it. And later on, it was very clear they weren't minimizing it because they were like, well, they didn't really understand what they did. No,
they were aware.
They were excruciatingly, intimately aware, and for lack of a better word, it scared the hell out of them. So better to act as if and put distance, and that's what the therapist early on gets to. That's why hope's important, because when you're feeling this, what am I getting? Because they're so used to immediate gratification. What am I getting out of this? One of the ways I explain it early on in therapy is, I explain it to the person. I tell them, I ask really silly questions. And here's a silly question. Have you ever had a poppy seed bagel? And they say, yeah. I say, so they're about that big a poppy seed, right? They go, yeah. This is how therapy works early on. Every session, you throw 1 or 2 poppy seeds into a 5-gallon drum. And we would then dump that 5-gallon drum out on the floor with 1 poppy seed in it. You're not going to hear anything without some kind of high-powered microphone. But at some point, that 5-gallon drum hits enough of a critical mass that when you pour it out, it makes a sound as the poppy seeds pour out. That's why hope's important. Because early on, particularly for someone with an addictive disorder history where they're used to, I feel bad, I use a substance, I feel bad, I gamble, I feel bad, I engage in a sexual act, and the feel bad is greatly reduced or eliminated rapidly. The idea of paying in for dividends later requires hope. And that's the therapist's job, is to keep reminding the person of what they're doing. They're working towards that. Every time they sit with a negative emotion, that's a step forward. Every time they express, that's a step forward. That's why I said hope is so important, because in this discipline, you don't get typically an immediate bang for your buck out of it. It takes a lot of time and a lot of effort, and many times 1 step up, 5 steps back, and you move through that process.
So, Keith, I think I'm hearing something else then. In addition to bearing witness, what you're doing as the therapist to inculcate hope is reminding them of their objective, reminding them of their goal, of the potential outcome.
Yeah. And Absolutely. And also framing it in context. You have to, the person has to know they may fail. And when you, for example, there's a concept in the relapse prevention literature. In the cognitive model of relapse, there's something called the abstinence violation effect. And basically this. Let's say an individual has been in recovery from alcohol use for a year and a half. And things happen, they had a bad day, and they go to a bar and they sit down and they take that first sip.
Gracias.
They now have a choice. They can think, okay, I took a sip. Oh, well, I blew it. So it doesn't matter anyway. So let me just go do this for a few weeks again, and then I'll come back. Or they put the glass down. They think, okay, I had a sip, and I walk away. It reminds me of near my parents' house, there's a factory, and outside is like one of those signs, like 109 days since last time lost due to accident. But how I think about it, they don't qualify what the accident is. So technically, if someone dropped a glass on the floor, is that an accident? They have to stop work for a minute to sweep up because someone dropped a bottle on the floor. That's an accident. If someone drives a forklift through the wall, that's an accident. But they're two very different things. And the abstinence violation effect basically says these are two very different things. All right, you took the sip. All right, you dropped the glass on the floor. What are you going to do now? And that's another hard part about instilling hope. Because to instill hope, you also have to instill the very difficult concept of choice and autonomy. Everything is choice. Thought dictates emotion, and emotion dictates behavior. But thought comes before emotion. It comes lightning fast, but it does come before emotion. And this idea that choice is there is sometimes a difficult one for the individual because A, it put the burden on them now for what I have to do going forward. But more importantly, if they have choice now moving forward, there's also a choice at some point also. It's not choice about whether or not to be addicted. It's choice about recovery from. Because there's a model of thought in addiction that argues due to the psychopharmacology, the neuropsychology of addiction, the individual, can't necessarily be held accountable for developing the addiction. They got caught up in a mega tsunami of psychopharmacology in their brain that they didn't know what they were up against. And okay, they're there. But with all that being said, they are responsible for their recovery. And that responsibility for recovery involves making active choices, such as the abstinence violation effect. Okay, I had a sip. Go back to insight. This is how I got to where I was last time. I got to step back. And what I always tell my clients is sometimes they come to me with those kind of stories. Those are good stories because you put the system through a stress test and it worked.
Yeah, right. And the next time you're stronger.
Yeah.
It reminds me of the quote. I'm actually going to send it on the chat now by Viktor Frankl, that between stimulus and response, there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. And that I think captures that moment that you're talking about when you can choose. Do I have a whole glass? Do I go back or do I refrain? Keith, I have about 300 more questions, and I'm not exaggerating. But I do want to take questions from the audience. So if you have a question, if you go down to reactions, press on it, and then put your yellow hand up, we will call on you. And just one final question, Keith, before we call on participants. So how about screens? How about technology? Is this an addiction? Are we addicted? Are many of our kids addicted? I mean, there's clearly a dopamine kick that you were talking about when we, check those likes or those email. Is it an addiction?
What I would say is this, in the current version of the DSM, there's always a chapter called Disorders in Need of Further Study, which basically is sort of like a bullpen that some of these disorders might become actual diagnostic disorders in the next version. So the ones that are sort of being thought about, worked on, they put the criteria out there so therapists can look at them with their caseload and see how it works. In there is internet gaming disorder, which is screens. And so I would argue internet gaming, phone, Kindles, iPads, there is an addictive component to it. I mean, how many of us walk around with our phone, and when we don't have our phone, we feel naked? How many of us, first thing you do when you wake up, you check the phone, you go to your favorite website, or if you wake up at 2 a.m, you go to the phone. So there is an addictive component to it, and I think it's interesting though, because I just remember, my kids all grew up with knowing nothing but Kindles and iPads and phones and stuff. But so I find it, this is all they've known. So I don't know. So I'm always fascinated to see what they think about it versus someone like me, where when I was young, there wasn't any of this, and when I got to be in my early teens, we had our first computer in the house. It was about like this big, one of those things, and so the idea of always being on a Kindle, on an iPad, on an iPhone, there is something addictive about it, but it goes back to what you emphasized earlier, which is, does it cause the individual distress? So if somebody doesn't go on their Kindle, is that distressful? If they can't use their phone other than to make a call or send an email, is that distressful? And you're sort of seeing it kind of is, that people do get a little bit, I need to just check this once more or look at that once more. But it's difficult because society's now built that we have to be wired up just about all the time.
Yep, a lot of work to do, Keith, for you and your students.
Okay.
Let's hear from you. So, Joe, you have your hand up.
Yes, sir. How you doing tonight? Thank you so much for your service. Really appreciate it. So I got a two-part question. I guess the first thing is, can power be an addiction? There's this thing about, addiction substitution, and I love that depression is sadness without hope, and that's been a key takeaway for me, the role in hope when it comes to addiction. I guess why this topic is important for me is, how do you get people to self-generate hope, right? Because at the end of the day, understand the role of the therapist in helping, giving somebody hope. But at the end of the day, I feel like one has to be able to source that hope internally, right? Because unless you have some kind of arrangement with your therapist where you can call them 24 hours a day and they pick up every single time. I'll end with this because I want to be respectful for other people here who might have questions. So my wife has a friend, right? And this is what I mean by addiction substitution. So she has some challenges with addiction to food, and went through a surgery, really transformed her physique. This was like 2 years ago. And since then, she's put on all this weight back, right? And what I find is that she goes to a lot of these seminars with motivational speakers, and she's bouncing around from different motivational speakers, one to another, and it just really made me think about that because she's put on all the weight, and I just think like it appears to me like maybe it was just a substitution on the addiction. So how does one self-generate hope? So you don't have to be dependent on a motivational speaker or on a therapist or an external factor. How can one get that from within? Thank you.
Wow.
That's a great question. That's a great question. And when you were asking it, I thought of one way to answer it. And I get that same question or response when therapy, because therapy is designed to some point end. Therapy is not designed to be forever. So therapy is designed to come, do its thing, and taper off. When we start getting to, let's talk about you're doing really well, we can taper off a little bit. Sometimes there's some fear about that. So I'll be honest, I take out my phone, I go to the calculator, and I do this. There's 168 hours in a week. Then we talk about how many hours do you sleep? Okay, there's amount of this. These are the waking hours. I see you once a week, twice a week. That's 1 hour or 2 hours. We're looking at ICU a fraction of 1% or a little under 2% of your waking hours every week. You're already doing it. 98, 99+% of your waking hours, you're out there in the world using what you feel, using what you think, using what you acquired in therapy. I think that's how you instill hope. You keep reminding the individual of hope is married to self-efficacy. If the individual believes that they have an ability to manage, maybe not well, at first it may be remarkably difficult, but they feel like, I could get through this. Hope is there. So I think the more you somehow instill at the appropriate spot and the appropriate doses, that notion of self-efficacy on the other end of that is hope appropriate for that moment.
Keith, again, you surprised me by connecting it to self-efficacy and what I was thinking. And as a response to Joe's question of a study that was run by a psychologist by the name of Schunk, who was a student of Bandura, who came up with the concept of self-efficacy. And the experiment was as follows. So they went to a school and they filmed students who were describing themselves as poor at math. And objectively, they didn't have good grades in math, but they filmed them. They filmed them for an entire week. And at the end of the week, they said to these students, you're actually better at, you're actually quite good at mathematics. You have the potential to be even better at mathematics. And the students said, no, I mean, we have terrible grades. We're not good at it. They said, no, you are. And here is footage. And what they did was they selectively picked footage where they successfully, efficaciously solved mathematical problems. And they showed them this. And suddenly these students were reminded that they're actually better than they thought because they focused on what they were good at. Mm-hmm. And as a result of it, their self-efficacy went up. And as a result of it, they actually became better students. And this goes to the root of much of what positive psychology, the science of happiness, is about, because it's about focusing on what works. And what you were describing here, Keith, is very much what I see as a positive psychological intervention. How do you instill hope? How is hope self-generated? By reminding them that they have done it themselves as well. Yeah. That they have gone through it effectively, successfully, efficaciously. And there's no reason why they can't do it again. So it's positivity or optimism, which is based on actual positive experience. It's not just, oh, you're great, you're amazing, you'll be fine. No, it's grounded optimism, grounded positivity based on reality.
Yeah, and that goes back to it's important because especially when they feel like things didn't go well. Okay, you feel lousy, you feel depressed, you feel stressed, you feel anxious, but you managed it. It didn't get a hold of you. You didn't go back and use. You didn't let the symptoms get mismanaged out of hand. All right, maybe you limped through your day. Okay, fine. But you limped through your day. You got through your day, and that's a win. And that's how you instill hope. You have to sometimes remind the individual what they already know, which is this is a remarkably difficult task that they're trying to do. They're trying to rebuild their life. Not an easy thing to do. And it's going to be difficult, and they're going to feel negative while they're doing it. But you can't, like you said in the study by Bandor. Now, look at what you did here and did here and did here. You may not think that's a success, but that's a success.
Yeah, don't ignore, don't take it for granted. Appreciate it. Amazing. Thank you, Joe, for the question. And thank you, Keith. Anne, can you unmute yourself? Thank you.
Yes. Hi. Thank you for tonight. And I agree about hope. I think hope is essential, yes, for recovery and for the family that are and friends that are trying to support the addicts. But earlier you said that they can't be held accountable for the addiction, but are responsible for the recovery. But some of the addicts that I know in particular are self-medicating due to a mental health issue, an illness. And in reality, it's their illness that is preventing them to make wise choices and stick with recovery. And so how do we get these people properly diagnosed? You know, it's great to have these programs, but if their mental health illness, whether they're bipolar or whatever, are not getting treated, how can we get that to happen?
Well, I think that's a great question. And the first thing I would argue is addiction is mental health. It's all the same. Everything we talked about with addiction is also relevant to mental health, because addiction is mental health. And when it comes to issues of bipolar, for example, with bipolar, right? How do they manage their depressive mood? How do they manage those symptoms? And oftentimes the discussion, you know, well, what are we trying to address here? You're not addressing the depressive symptom. You're addressing the prior mismanagement of that depressive symptom. Let's say there's no alcohol or drug at all for a moment. What are they doing with the symptoms? Are they actively engaging with them? Are they trying to work through ways to keep the depression? Are they trying to not let it get the better of them? Are they trying to refute any of the negative self-talk in their own head so they don't think, okay, well, this is the only reason why this must be, and since it's such a bad reason, they focus on that, and that ramps up the depression, ramps up the anxiety. So the idea of co-occurring mental health and addiction is a very, very common concept. And there's all these different models of co-occurring. The one I endorse is called the reciprocity model. It doesn't care what came first. Depression, addiction, mental health, addiction, it doesn't. What it basically says is one exacerbates the other. And to look at it overall, right? Where are they not engaging with dysfunctional, unhealthy parts of their life, whether it be on the mental health side or the addictive side? So, and I hope that answered your question in some manner. Your question was a great one, because your question was basically the umbrella concept for a graduate course I just got done teaching. I just got done teaching a course on co-occurring mental health and addictive disorders, and the whole course was basically about what you discussed here, that the individual, you know, has the addiction, there's all that neuropsychology and psychopharmacology there, and they have mental health issues as well, and they exacerbate one another, and how you work with both of them. It's a very complicated concept.
And is the basic idea...
Well, thank you for trying to answer
it. Thank you, Anne. So Keith, is the basic idea here, they're interconnected,
Yes.
They affect each other. And therefore, you know, if you think about your experience as a system, an interconnected system, you basically can affect the system wherever you start, because if everything is interconnected, everything affects everything else.
Mhm.
So whether you focus on specifically on the addiction or you focus specifically on the, bipolar, you are potentially affecting the whole.
Yeah, I don't, when someone has co-occurring addictive and mental health disorders, they're just so intertwined with one another. I mean, the addiction is there to as their strategy to engage with and manage their mental health disorders, and it's intertwined to such an extent. You just address the symptoms as that are there, and you don't worry about, does this symptom live in this house or that house.
Right. Thank you. Adina.
Hi, thank you for the wonderful discussion today. It was great to hear everything. I'll give a background to my question first. So I'm an environmental psychology researcher and consultant. So I always look at the environment, whether it's family, it includes a lot of elements, but I always look at behavior as in context, right? And so because you were talking earlier about hope, how would you see the connection between hope and self-worth? Because most of the times addiction is running away from something or feeling that there's, like lacking self-worth for whatever reason. And that is very connected with the environment, and here I will refer more to the people around, right? So whether there's encouragement, even in the experiment that Paul was talking about earlier, with the kids with math being made to believe that they're good at math. That was part of the environment, making them believe that they can and feeling that self-worth. So I would be curious how you see this, because if you cure your addiction, I would see it as the hope coming from, I have something to go back to, and feeling worthy of that.
That's a great question. I mean, self-worth is just one of the integral components across all of mental health and addiction. And so I agree with everything that you said. I think one way I can try to explain self-worth a little bit is in some of the work I do with some individuals who have a sex addiction. And what happens there, not all the time, but I've had many over the years with this paradigm in place, whether it be just in general or due to co-occurring depressive, anxiety, etc. disorder, there's low self-worth. And then what they figured out is their quote unquote drug of choice was sex. And through the act of sex, they were sort of outsourcing their self-worth. If this person wants to have sex with me, that boosted their mood, that boosted their sense of self-worth. So what they were doing is always chasing after the next dose of self-worth. And one of the things I always discuss, and that is the case, is you're outsourcing self-worth to somebody else. And what's the first word in self-worth? Self. You're outsourcing self to somebody else. And then when that's done, the next one. So self-worth is one of the important concepts, because self-worth is one of those things that grows out of hope. That's why I said at the start, sometimes no matter what the therapy is, I firmly believe at some point why I so respect every individual I ever worked with is at some point I recognized very clearly early on, despite everything in front of them, they had to take a leap of faith. And this is the kind of leap of faith where you take a leap and you figure it out in midair. And that's a big deal to ask of somebody. And so I think self-worth is remarkably critical in all facets of mental health and addiction, because if the individual doesn't feel a secure sense of who I am and I have value, it's difficult to latch hope onto that. That was a great question. Thank you.
Thank you for the question. And Carol.
Hi,
Hi.
good evening, good morning to everyone. Difficult here to know. Thanks for the class, it's been amazing. I feel that we are going deeper and deeper in this conversation in the direction of, we started in the symptom, how to treat the symptom. And then we are going nearer to talking about causes. And comes to my mind specifically food disorders, because I have patients with obesity, and patients with anorexia, and both very complex, as you know, especially anorexia, very complex. So I would like to understand in your work, if you are really working not just, but only in the symptoms, or if you are dealing with something near the causes and what generates. And when we are talking about self-worth, I think we are getting nearer to this. So I would like you to comment.
Yeah. I mean, the symptoms are important, but the main thing that I guess you can say, a therapist like me does is we sort of assist the individual in some ways to reverse engineer their day, their week, their month, their year, and consider what thought they're having and what emotions they're having and what they're doing with those thoughts and what they're doing with those emotions, what works for them, what doesn't work for them, and the sort of rebuilding a way to navigate the world. And it's a matter of, okay, you used to navigate the world this way with depression, whatever, symptom mismanagement, with addiction, self-medication. Okay, that's gone now. So how do you engage with your thoughts in the world? How do you engage with emotions in your world? How do you deal with a rough day? How do you deal with, okay, you can manage your depression all you want, but you're going to have a down day. How do you deal with that? How do you think yourself through? How do you sit with it and say, okay, this is what I'm thinking, and here's why I'm thinking it. Here's what I'm going to do with it. How you work through those things. And that's sort of the work I do. So the symptoms are important, but we discussed earlier, the insight in regard to, okay, what am I doing and why am I doing it? How did I get here? That's kind of the work that a therapist like me does, because at some point, like I said to Tal a little while ago, therapy is not forever. And at some point, the individual is out there in the world again on their own, ideally mirroring much of the stuff we did in session over time.
If I'm allowed, but you don't go, like, for example, in the cases of obesity, I see a huge number of cases linked to abuse, usually sexual abuse. You don't go there to the sexual abuse, you stay with food disorder?
Well, it depends on the case, obviously. It depends on the case, depends on the issue. But one of the things to address, that's a good question also, Carol. There is sometimes you do need to go to history. Yes, sometimes you need to go back to history. But oftentimes the history is what's important is what's happening now. Because the history is there. Okay. You can visit that history, understand that history, but what happens now? Because that history is always going to be there. What are you doing with that history now? Perhaps now in a more functional, healthy manner than you used to. So, for example, worked with a great number of people with PTSD. The trauma will always be there. It will always be there. And there's not a therapy I know that can get rid of history. It's always going to be there. Okay. Understand that history in the current and how you coexist with that history in a more healthy current. Thank you.
And Keith, of course, hope connects you to the future.
Mhm.
So yeah, of course, you have to take into consideration the past, bring them to the present, and have the future pull you up.
Yes.
So if it's okay, we'll take one more question, Keith. I know we
Sure.
are
Sure.
over an hour.
Absolutely.
So Imola.
Hello, everyone. I apologize for the camera off, but it's 2 a.m. in London, and I'm in bed.
Thank you very much. Thank you very much for attending at 2
So
a.m. in London.
so I hope that a question will come out of it, but I was thinking around what you said on the topic of self-worth, and I have had so many takeaways from this conversation, the awareness versus insight, and that's so true, and the neurotic anxiety, I think you said, where there is this rather the anxiety than having to face the insights that needs to be seen. So and I think that I have friends who are dealing with addiction, and in regards to self-worth, it often seems the case that this chasing of a sense of self-worth is at the core of the addiction.
Yeah.
And I'm wondering, and also with hope, with the recovery, they have been recovering. Some of them have been recovering for years. Some of them have not yet stepped on the road of recovery because, they are not yet there. But there is this sense that you are never truly recovered from addiction, but you are always in recovery. And yes, so there is something with hope. What is the best that you can hope for? Or also recovery happens from one day to the next, so one day at a time. That is what I hear a lot.
Yeah.
So there too, so yes, it's just how can it's just sometimes the hope doesn't seem to be very strong. Hope give a strong enough grip to stay on course.
Yeah, I think
sometimes.
that's a really excellent question. And the first thing you said about recovery is basically never ending. From a diagnostic standpoint, you're not considered in early recovery until 3 months of sustained remission. So if someone is 2 months sober, from a diagnostic standpoint, it's just considered they're on a pause in between drinks. It's not until 3 months you're considered sustained. You're considered in early. And early runs month 3 to month 12. And then to get to your excellent question, once you get to month 13, you're in recovery. Month 13, you're in recovery. Month 113, you're in recovery. 513, you're in recovery. It's lifelong. And another thing that you brought to mind with your great question is a phenomenon I've seen over and over again, and many therapists see this notion of the individual has crafted a narrative. And it's a narrative focused on negative. And the paradox I see often is because of the fear, because of the discomfort, because of the leap of faith required, because it's just been so long, they've been doing it one way. You get this bizarre paradox where on one hand, they want to be rid of this narrative. But on the other hand, they sometimes hold on to it really tight and won't let go of it. And I think getting back to where we started from, that's hope. You got to have hope that if I craft a new narrative, it's going to be better than this one.
Yeah.
But you're right. People chase self-worth. They chase self-worth everywhere. And it's a chase that is never going to be achieved because self-worth that doesn't come from somewhere else. It comes from within.
Yeah, exactly. Yeah. Thank you very much.
You're very well. Thank you.
Thank you, Imola. You know, I'm sitting here and listening to you speak, Keith, and it's just, I must say, I'm blown away by how many parallels there are between your field, dealing with addiction and substance abuse, and the field of happiness studies. You talked about hope, which is central to positive psychology. You talk about self-worth and self-esteem, which is something we talk about a lot. And now you talk about narrative. And, we talk about storytelling and narrative as the unifying theory of psychology, because you find it in therapy, you find it in work on memory, cognitive psychology, you find it in child development, you find it in leadership. Best leaders are storytellers. In every area of psychology, you find, the narrative approach. And just like I felt after attending your class, a sense of optimism, because I knew that the future clients of your students are in good, compassionate, and professional hands. So I feel today very optimistic and excited about the work that I know that we can do together at Centenary University, with collaborating with the Happiness Studies Academy. There's so much that we can do. And yes, there's a lot more awareness today and attention paid to the distress and dysfunction that is caused by addiction. And I also think we have many more tools today to help those in distress, those experiencing dysfunction, to help them, as you put it, rebuild their lives. Yeah. And what more important work is there in our world than to help all of us build and rebuild our lives.
Yeah.
So thank you very much, Keith.
Paul, thank you very much. Thank you.
Thank you for your time this evening, and for raising and elevating a whole generation of therapists who day in and day out within the four corners of their room, in quiet, are making a difference and literally saving people's lives. Thank you for that.
Thank you, Tom.
And thank you all for being here. And remember to take care of yourself so that you can better take care of others. Bye-bye.
Well said.
Tal is the master teacher of happiness.
I think he's so brilliant and wise and kind and humble. Everything that Tal teaches is based in science, that it's very interdisciplinary. And I love the fact that we draw on economics and science and psychology and literature and art and just everything as the holistic approach, and everything is interconnected.
You gave me this evidence-based, science-based tool, and I'm always grateful to you. Wherever you go, I'm going to follow you. That's it. You're not ever going to get rid of me.
Hello, everyone, and welcome. California, Mexico, China, Greece, Paris, Singapore, Indonesia, Ireland, Toronto, Argentina. Wow, that's amazing. HSA is not a certificate program. HSA is a community.
I signed up for the material, and the teacher, obviously world renowned and wonderful. What I didn't realize is that I was going to get a community that is so wonderful. There are people from all parts of the world, and it just makes for such a rich conversation. And of course, events like this where we get to meet in person just really solidifies that the community is made up of like-minded individuals, professionals within their own fields that are leaders and want to take this material that we're learning and spread it with the rest of the world. And the friendships made are what makes us all happier in the end.
When you find a community of people who want to live purposeful lives, then it just amplifies the experience that we're all here to share together.